Welcome to the video on therapeutics. My name is Ben Geisler and I'm an internist and a hospitalist at Massachusetts General Hospital in Boston in the United States. I'm also an outcomes researcher and my passion is to discuss clinical trials and other studies with my colleagues and to apply the evidence to the patient. I'm very grateful to Dr. Southwick for letting me present this part of the course to you. In the next 15 to 20 minutes, we'll first go back to our case, and then we'll discuss several unspecific treatments with an unknown benefit, as well as two COVID-19 specific treatments with a proven benefit, Remdesivir and Dexamethasone. We'll then talk about how to keep track of new emerging evidence. We'll discuss equipoise and whether patients should be enrolled into clinical trials. And finally, we'll apply everything back to our case and summarize. Here are the relevant disclosures, the most important one being that all the evidence presented here is expected to change rapidly in the near future, which is why it is so important that you keep track of the new evidence. So back to our case. Our patient was a 30-year-old Spanish-speaking male with no known past medical history, who presented with 5 days of progressive, non-productive cough and dyspnea. Let's add some more data. On exam, the patient was found to be wheezing, with a heart rate in the 110s and a normal blood pressure. He was SARS-CoV-2 positive by PCR. C-reactive protein, D-dimer, ferritin, LDH were all elevated, and the procalcitonin was normal. The white blood cell count was only mildly elevated, but there was absolute lymphopenia. BUN and creatinine were elevated, and there was a normal CPK, ALT, and AST. On chest CT, multifocal ground glass opacities were seen, but there was no infiltrate or airspace disease. On the floor, the peripheral pulse oxygenation was 89% on room air, but after you took care of the patient and started them on 3 liters nasal cannula, the oxygenation improved to 94%. Let's first talk about bronchodilators. In this context, we mean short-acting beta-2 agonists and or anticholinergic drugs, or the combination. So for example, in the US, this could be albuterol and ipratropium, or the combination duonaps. There is no data and there's no experience with long-acting bronchodilators, inhaled glucocorticosteroids, or other treatments for obstructive lung disease. Indications for COVID-19 are if the patient is using bronchodilators at home for asthma or COPD, or if they're wheezing on exam in an effort to improve their oxygenation. Remember that nebulizer treatment is aerosol generating, so immediate dose inhalers are preferred as the routine treatment, but as always, increased risk with nebulizer treatment needs to be weighed with the additional potential benefit. If a patient is newly started on a immediate dose inhaler, they need to be taught the proper technique. Intravenous fluids versus diuretics. COVID-19 patients should not be on standing fluids. If they need nutrition, consider tube feeds via nasogastric tube instead of intravenous dextrose. Avoid extremes. Be cautious with intravenous fluids unless the patient is hypotensive, and even then consider early vasopressors. Be also cautious with diuretics as patients with COVID-19 are at risk for acute kidney injury. Assess volume status as usual, and consider measuring the input and output, and of course also factor in lab parameters and other data. Antibiotics should be avoided as a routine order in every COVID-19 patient, but you should have a low threshold to add them if you suspect a bacterial infection. Infiltrates or airspace disease on imaging are certainly a good reason to start them. If you're uncertain about this, talk to your radiologist. The use of procalcitonin is controversial in general, but most would agree that antibiotics should be started if the procalcitonin is positive in COVID-19 patients, especially if this is on admission. As always, tailor the antibiotics to the infection that is suspected. So, for example, in community-acquired pneumonia, one regimen could be ceftriaxone with either doxycycline or azithromycin. Doxycycline might be preferred in non-pregnant patients, and azithromycin might be preferred if the patient is unable to sit upright for 30 minutes to prevent pill esophagitis, or in pregnant women. Remember that azithromycin can cause an increased QTc and associated arrhythmias. Do stop antibiotics if the risk of bacterial infection is low, unless the patients are critically ill. And if in doubt, you can consider an infectious diseases consult. Venous thromboembolism prophylaxis versus therapeutic anticoagulation. Unless it is contraindicated, all patients with COVID-19 should receive pharmacologic VTE prophylaxis. Mechanical VTE prophylaxis only prevents deep vein thrombosis in the lower extremities, whereas COVID-19 patients could have thrombosis elsewhere. Except in pregnant patients, where subcutaneous heparin is preferred, low molecular weight heparin might be the preferred option for many patients. Retrospective data interestingly have shown that therapeutic dose anticoagulation has shown a mortality benefit in patients with an increased D-dimer. And this mortality benefit correlated with the degree to that the D-dimer was elevated. However, this is currently being studied in prospective observational studies and in trials, and is not standard of care yet. In terms of statins, there is certainly a theoretical benefit, as they are mild immunosuppressants. They should be continued if the patient is on them at home, and also if there's an indication for major adverse cardiovascular or cerebrovascular prophylaxis per the guidelines, except if the patient is pregnant. In that case, consider newer statins and do check the medication list for potential drug-drug interactions. Anecdotally, there is a risk of statin-induced myopathy in COVID-19 patients, so do not start them unless they're indicated. And before starting a statin de novo, check a CPK, ALT, and AST. There is a worse risk-benefit ratio if the CPK is over or equal to 500, or if the ALT is over 3 times the upper limit of normal. If the patient is on statin and azithromycin, a daily CPK should be checked. NSAIDs and renin-angiotensin aldosterone system agents have been controversial. They could either be a theoretical risk or a theoretical benefit. For example, there could be enhanced virus uptake if the ACE receptor is upregulated, or there could be competition with the virus for the receptor by these agents. There is no clear evidence one way or the other. Retrospective studies have shown, though, that there is probably no harm in continuing RAS agents such as angiotensin converting enzyme inhibitors or angiotensin II receptor blockers. And major societies have recommended against stopping ACEs or ARBs. Likewise, for NSAIDs, the situation is unclear. If the patient needs analgesia, acetaminophen or paracetamol might be the preferred option. But do consider to avoid antipyretics altogether, as to not mask fevers. Now on to the first COVID-19 specific treatment. Remdesivir has an antiviral effect. The mechanism of action is not entirely clear, but it probably blocks viral RNA synthesis. A randomized controlled trial has shown that the duration of illness was shortened with remdesivir compared to placebo. The mortality difference did not reach statistical significance, but many expect this to be the case in future studies. The US Food and Drug Administration has granted an emergency use authorization for remdesivir, and it is generally indicated in adults, including pregnant women, and in children with severe disease. For example, those who are hospitalized with a pulse oxygenation of 94% or less on room air, or who are on supplemental oxygen, who are intubated and mechanically ventilated, or who are on ECMO. Remdesivir should not be started and should actually be stopped if the ALT is 5 times or greater the upper limit of normal. It is very difficult to access in many places. It is expensive, it is an IV medication, and there's a shortage given the demand for this new drug. But if it is available, you should consider starting remdesivir early if the patient qualifies. Dexamethasone is the second specific therapy for COVID-19. Early on in the pandemic, steroids were used in about half of the patients in China and in other countries. Others were reluctant to use steroids because there was a negative signal for steroids in SARS and MERS, and mortality can also be increased with steroid use in influenza. A randomized controlled open trial, part of the recovery trial, has shown a mortality benefit of dexamethasone in severe COVID-19, except in those patients who did not have an oxygen requirement. The dosing in the trial was 6 milligrams daily for 10 days or less. Dexamethasone can also be given IV if you suspect gut edema or if it is back-ordered. And there's no data on other steroids, but they should also work. So if dexamethasone PO is not available, you can discuss with pharmacy or with your colleagues. This chart shows the 3 stages that are hypothesized for COVID-19. Remdesivir might be effective in the viral replication phase, so it should be given on early in the infection. Dexamethasone might influence more the host inflammatory response phase. Let's talk next about how to keep track of new evidence. One good way is to follow the IDSA guidelines that Dr. Southwood has already described. You can get the updated guidelines via an app. Just Google IDSA guidelines and app. The National Institutes of Health also author COVID-19 treatment guidelines. Our own hospital has a service called Flare, which sends out an email with a comment about any new evidence on COVID-related topics. The New York Times has a tracker of COVID-19 treatments and their color code in what stage the evidence currently is. And finally, on our own website, coviddrugs.org, we are conducting a living systematic review of COVID-19 specific treatments. Equipoise is defined as genuine uncertainty among experts whether a new treatment will be beneficial or not. In most situations, we would all agree that patients should be enrolled in high-quality randomized controlled trials. On the other hand, in other situations, doctors and providers are generally allowed to prescribe drugs and other therapeutics that are approved for other indications. That's known as off-label use. In the case of COVID-19, there is an ethical dilemma. On the one hand, you want to conduct these trials to know with certainty whether a treatment works or not. On the other hand, if most or all cases are happening right now, if there is a certain mortality present, will future knowledge be less useful than treating patients now? Let's go back to our case and apply the evidence to our patient. The patient was wheezing on exam, so he should certainly be given bronchodilators unless there's another contraindication. His heart rate was elevated, his blood pressure was normal, and the BUN and creatinine were elevated. So the patient should presently not receive diuretics, and intravenous fluids can be considered. COVID-19 was confirmed via PCR, and the labs seem to be compatible with a severe disease. There's also evidence on imaging for COVID-19 pneumonia. And the oxygenation is 89% without oxygen. So the patient would qualify for both Remdesivir and Dexamethasone. On the other hand, there's no evidence for a bacterial pneumonia. There's no infiltrate and no airspace disease on imaging, and the white blood cell count is only mildly elevated. Moreover, the procalcitonin is normal, so unless the patient is critically ill, they should probably not be started on antibiotics at this point. So to summarize, bronchodilators should be stacked aggressively if the patient is bronchospastic. Intravenous fluids should be limited as you are able to. You can consider diuresis. Definitely consider antibiotics if there's an infiltrate and elevated procalcitonin or any other evidence of a bacterial infection. Strongly consider DVT at a prophylactic DVT prophylaxis at a prophylactic dose, for example, low molecular weight heparin. Consider statin therapy if there's an indication or if they're on it at home. Continue ACEs or ARBs. Acetaminophen, paracetamol are preferred over NSAIDs if they're needed at all. And then consider remdesivir early for severe cases, and dexamethasone or another steroid if dexamethasone is not available for an oxygen requirement, an SpO2 of 92% or less. Keep in mind that all this evidence will change, and keep track of the new evidence via the IDSA guideline apps, the NIH guidelines, the MGH Flare email service, the New York Times COVID tracker, or via our website coviddrugs.org. Thank you so much for listening to this, and we see you in the next video.